Okay, so basically it resists the vellus and varus deformities. What's valgus and what's varus deformity? Here you guys can see it's valgus. Okay, you have an inverted V, right? So it's like common if you have damage to this ligament. So this bone is going to move like that and this like that, right? So you are going to see an inverted V. Okay, and this movement is basically known as valgus movement, right? If this the medial collateral ligament is damaged, you know the you will be having like valgus movement, exaggerated valgus movement, right? Okay, if the lateral one is damaged, simply your leg is going to move like that, and this bone is going to move like that, right? So you will be forming a straight V, inverted V for valgus, and straight V for varus, right? That is your missing bowing of your leg. Simple. Okay, medial collateral ligament. Let's discuss the insertion site and the site where it arises. Medial, it arises from medial epicondyle, guys, not condyle. Okay, and on the medial condyle of tibia, simple, and it would result, it would resist the valgus movements or valgus stress, right? The lateral, basically, it arises from the lateral epicondyle. Here, you guys can see the lateral epicondyle, and it's going to insert into the lateral condyle of your tibia or head of your fibula. Sorry, because laterally you have fibula, right? Not tibia. It would resist the varus movement. Okay. Then you have your menisci, as we have already discussed. You have two crescent shaped pads that are present in between the joint. Here you guys can see these are the menisci that are basically made up of, you have cartilages and fibrous tissues which make these pads. Okay, and they are also they are present between tibia and femoral condyles. Simple. Your tibia and femoral condyle. Okay, so what's knee injury? It often, for example, if you have tears to ligament or menisci, if you have tear, you're going to see swelling, instability, and it would be difficult to walk. Simply, okay. How does the anterior cruciate ligament injured? We have already discussed. Okay, so anterior cruciate ligament is basically injured in non-contact athletic injury. It's basically due to non-contact athletic injury. For example, if a person is running, if he is jumping, right, and sudden changes of direction, it can lead to injury of anterior cruciate ligament. As already discussed, it's a most commonly injured knee ligament, right? And this person would say that I just hear a pop in the knee while I was just pivoting or running or jumping simply. Okay, so you're going to see an MCQs related to anterior cruciate ligament injury. Okay, and how to check whether anterior cruciate ligament is like torn? We have already discussed the anterior drawer test. Just patient in supine position, his leg, just move it forward, right? Like 90-degree angle between your leg and your thigh, and just move forward. If you have more movement as compared to that of a normal individual, it would indicate that you have damage to your anterior cruciate ligament. Or simply, it's also, you can also use another test that is known as Leishman test. Like just have a 30-degree angle like that, okay, and then just pull it. So the idea is same. You are basically checking the activity of your anterior cruciate ligament. Okay, so posterior cruciate ligament, it's also known as like it's also damage in the dashboard injury. How the dashboard injury? For example, if a person hit a car, so it means his knee is going to like hit the dashboard simply. So as I have already discussed, when you have direct injury to your tibia, right? So it can damage your posterior cruciate ligament. Simple. You're just pulling backward your tibia. So often from trauma, force directed posteriorly at knee, okay, dashboard injury. Patient in supine, again bend 90%, and this time just move it like this. Patient in supine, 90%, 90-degree angle, just move it backward. If you have more backward movement, so it would indicate the damage of your posterior cruciate ligament. You're going to see an MCQ on you world, right? That we have a patient, he just hit a ground. Okay, he was playing And what do you guys think? Uh, what do you guys think happened? Which ligament is like torn or damaged? Simply that's posterior cruciate ligament. So the idea is simple. Okay. Now, medial collateral ligament injury, as already discussed, whenever you have injury to this medial collateral ligament, you are going to see valgus deformity, inverted V, right?
Yes.
So, basically, this is the this damage in contact sports as well as non-contact damage by valgus stresses, contact as well as non-contact, right? So, abnormal passive abduction, for example, it can happen in abnormal passive like abduction. For example, those who are playing basketballs or some like MMA fighters. Okay, so what happens? So if we have exaggerated abduction, what's abduction? Moving away, right? Adduction, you are adding it. If you have exaggerated abduction of your leg, so it can also have impact on this medial collateral ligament, right? And it can be torn simply. So this was all the idea of the medial collateral ligament. Okay, what's an unhappy triad? Unhappy triad when you have damage to three ligaments, that is anterior cruciate ligament, medial collateral ligament, and medial meniscal tear. So this happened whenever the lateral force is applied to the knee. For example, this is a person standing, it's his knee. For example, if you have lateral force applied, right? Let's suppose if someone is playing football and someone kick him from the lateral side on his knee simply. So the impact would be on your medial side, right? So the medial side is going to injure the medial collateral ligament, and as well as that, the commonly injured anterior cruciate is also going to be torn, right? And the medial side meniscus is also going to be affected. So this is basically known as unhappy triad. You are going to see three things in unhappy triad in contact sports. Hitting from lateral side. Hitting from lateral side, you are going to see impact on your medial side. The most common, that is anterior cruciate ligament and medial meniscal tear. Here you guys can see this is force directed from the lateral side. You can see damage to the anterior cruciate ligament, your your medial collateral ligament, and your medial meniscus. Okay, so lateral collateral ligament, like it's very rare to have injury to lateral collateral ligament. Like the idea is simple. For example, this is your knee, this is your lateral collateral ligament. So it's very hard to have impact from the medial side, right? Like you do not see such kind of things normally in your life. If someone have force applied to the medial knee, so then it's going to damage the lateral side, right? But it's like rarely seen. Okay, so it can be due to often trauma to the medial knee. What if person is having trauma to medial, so it can occur, but it's rare, right? Okay, so abnormal passive adduction, like if I am just steering it, so your leg is going to move like that, right? And your femur is going to move like that. So you're going to see adduction. Okay, passive. Okay, so force from the medial side, and as a result of that, your lower leg towards the midline, that is adduction, and the lateral space widening. This lateral space, it's going to widen. Simple. So, okay. Anyone who can just give us a quick overview of the topics that we discussed? Hello. Yes, Dr. Renu. Can you just quickly tell us the
Mm,
ligaments, the medial and condition in which they are teared, and the trust drawer test?
okay. So, we have like anterior cruciate ligament and posterior cruciate ligament because they are
Okay.
like cross shaped. So the name
Yes.
cruciate. So the ACL, it attaches on the like the anterior tibia,
Okay.
and for the means like diagnosis, we do the anterior broad rest, and we
Yes.
place it like at 90 degrees angle, and we pull it upwards, and if it is
Yes.
like stretching beyond normal, so that's like positive. And
Yes.
similarly, the PCL, the posterior cruciate ligament, it attaches to the posterior tibia, and same posterior draw test, we like pull the knee like towards the down, and if it is like pushing more than the normal, then it is like positive test.
Okay, can you just tell us the conditions or the most common injured one cruciate ligament is?
Yeah, the athletic injury, contact sports.
Yes. Like
Yeah.
normally it happens in non-contact sport. For example, if a person is
Yeah.
running, if he's jumping, but it can be a part of contact sport that is unhappy
Mm.
triad. It can be a
Um,
part of that, right?
yeah. And PCL tear will be most likely with that
Dashboard injury.
dashboard injury. Yes.
Yes.
And then we have the collaterals, the medial and the lateral collateral ligaments. So when the medial collateral ligament is torn, so there will be like valgus deformity, like a abduction, because the force is coming from the lateral side. And
Yes.
since the medial collateral ligament is not able to hold it, so the MCL is torn off and the leg is deviated away from the midline.
Okay.
And the lateral collateral ligament tear is very rare because it's very unlikely that we will have injury like a force from the anterior side,
On the medial side.
from the medial side, sorry, from the medial side. And if it happens, then there will be like adduction,
So it can cause
like
injury of you.
injury of your
Yes.
lateral collaterals.
Yes.
Yeah.
Okay. So let's discuss the meniscal tear. So how can the meniscal be torn? So it's often like it occurs when foot is planted. Like for example, if a person is standing, simply you can say. Okay, and sudden change in direction. For example, if you are changing the direction, or you are internally rotating or externally rotating, yeah, right? You are a femur, so it can have damage to those pads, right?
Mhm.
For example, in basketball, in soccer, right? So what if it tear or damage? You will be having pain and swelling as a result of that injury, right? And pain is going to be worse while twisting or pivoting. Simply, if you are standing or if you are twisting and you have tear of your meniscus, so there would be pain. Simple. Okay, so we basically performed a test that is known as McMurray test. So what is McMurray test? As here, let's read. So patient is in a supine position. Okay, so flex. Okay, flexed bend knee held by the patient hand, by the examiner hand. Okay, so you are going to flex the knee, like you're just flexing the knee, right? Okay, let me read it first. So you have flexed bent knee. Okay, foot by the examiner on the other hand. Stand while rotating. Pop from McBay. Okay, so the idea is that first of all you are going to have the patient in a supine position. Then what are you going to do? You are going to bend. Okay, I'm not getting what have that. Flex knee held by the examining hand. Okay, so you are going to pull the leg like that, and you are going to basically undergo internal or external rotation. The idea is, if you have meniscal tear, you are going to see the pain. Okay, we will discuss it later. I haven't just, I think, revised this slide. Sorry for that. Okay, let's come towards in knee. Okay, anyone who know the McMurray test, who can just tell us the McMurray test. Okay, okay. Basically, the idea is that you are rotating, you are seeing the
Yeah, exactly.
menisci during rotation. If you are
Mm.
internally rotating or if you are externally rotating, so you are going to see.
Mm.
Okay, so you are, yes, yes. If
Yeah.
you have lateral, if you are internally rotating, like to inside, like that.
Mm.
Okay, this is your knee. If you are
Towards the
internally
midline
rotating, so you have more impact on your lateral
of the meniscus.
meniscal, right? If you are externally rotating, so you have more impact on if there is pain or pop in
Yeah.
the medial side. So you'll be seeing pain. Simple. It's known as McMurray test. Okay.
There is one mnemonic for this.
Yes.
It's
What's the mnemonic?
lime. Lime, Lime. It's in the first aid.
Okay. LIME. What does Lyme stand for?
So, like if the lateral meniscal tear, the internal rotation you do the internal rotation
Okay.
and you hear the pop sound, that is like lateral meniscus is gone. M
Okay.
is for the medial meniscus and E is external rotation. So, if you rotate it externally and you hear the pop sound, so that means the medial meniscus is
Okay.
gone.
Yes, that's good. If you are laterally rotating, as Dr. Renu said, okay, so you'll be seeing that is uh,
Internally
if you're
rotated.
okay internally rotating lateral
Lateral is gone. Yeah.
yes meniscus. So let's discuss the knee. So you have it's basically a synovial joint. It's going to connect your bones, and it have a synovial membrane too and synovial fluid, which is going to avoid the friction between the both of the bones, right? So bursa, you are going to see a lot of MCQs related to bursa. That is pre-patellar bursa, right? It's basically present like anteriorly to the your patellar bone. So it's basically a synovial filled sac, synovial fluid filled sac, and it's also like provide a cushioning effect to your bones and tendon. Simple, okay? So you have four bursa near the knee. Okay, let's discuss the four bursa. One which is anterior to, okay, the patella, right? That pre-patellar bursa, right? For example, this is your patellar bone. So, okay, where is your patellar bone? Here, right? So, the anterior bursa, that is just a fluid-filled synovial fluid-filled sac. It's no, it's got, it's known as pre-patellar bursa. Okay, and if you have repeated kneeling, that is house-made knee, so you can have injury to the or impact on the bursa, right? That is pre-patellar bursa. It can also happens in infections and gout, right? So in bursitis, what are you going to see? You are going to see swelling, that is anterior to patella, as well as warmth, as here you guys can see. So pre-patellar bursa, you are also going to see an MCQ in the world related to pre-patellar bursa. Okay, so for example, if a person is kneeling and he have like contact of like his knee on the floor, so it's going to have impact on this bursa, and as a result of that you can have inflammation of, that is you are going to see swelling and warmth of this bursa. Okay, that is known as pre-patellar bursitis. Baker cyst, you know, this is your popliteus, right? So here you also have a fluid filled bursa kind of thing, right? So that is basically present in the posterior, in the popliteal region. So it's also a fluid collection, right? And you have your muscles, that is gastrocnemius muscles, your semi membranosus, right? So somewhere present here. Like it can also impact some of your nerves that we will be discussing. For example, your your tibial nerve, right? So we'll be discussing it on our further slides. Okay. So the gastrocnemius, the bursa between the muscle tendons. So it often communicates with the synovial space. Okay. If it's in communication with your synovial space, so it means it also have an impact on that joint as well, that we have already discussed. Knee joint. Okay. So okay. So you have your Baker cyst. Okay. You just give me a second, please, guys. Okay. So Sometime you can have a cyst here, and it could also impinge some nerves, which we'll be discussing furtherly as we go to the nerves of the lumbar plexus, right? So Baker cyst, it's often small, asymptomatic, and it may cause the posterior. Okay, for example, if someone have Baker cyst, that is cyst in the popliteal fossa, so you will be seeing pain in the popliteal fossa right here. Yes. Okay, and pain is basically due to prolonged standing. Okay, and what are the symptoms? You'll be seeing swelling there, right? And it can also mimic DVT, deep vein thrombosis, right? And it's commonly associated with your rheumatoid arthritis. Here you guys can see this is your Baker cyst right in the popliteal fossa. Okay, what's Osgood Schattler disease? You're going to see a ton of MCQs related to it. The idea is that, for example, this is your knee, your knee joint. You have your patella. You know that patella, the rectus femoris muscle tendons are going to cross the patella, and it's going to be inserted here on the tibial tuberosity, right? Tibial tuberosity. So the tibial tuberosity basically undergoes secondary ossification. What's secondary ossification? You guys know. First of all, normally what happens, you have the like all of these points first are used to be cartilage, then they are going to be ossified, right? So secondary ossification center. So due to this reason, it can commonly injured, like the tibial tuberosity is the common site for injury. It can, you can see injury here on the tibial tuberosity. What's the reason? You have secondary it's a secondary ossification center of tibia, right? You guys are going to see an MCQ related to it. So here you guys can see it occurs mainly in the children. So you are going to see pain, swelling in the tibial tubercle. Okay, it can happen due to overuse, right? So you're going to see injury or breaking of this tibial tuberosity due to overuse. Why? Because it's secondary ossification center of tibia, right? Okay. So patellar fracture, for example, that small bone which we discussed. For example, if you have fracture to that patella, so what happens? As you guys know, that all of the force from the up, this muscles are going to be transmitted through the patellar bone, right? So if you have injury to this patellar bone, it means the person cannot stand well, right? You would be having deficiency, difficulty while standing against gravity, right? Because now you do not have this small bone in order to transmit the forces and equally divide it on all the bones. So how does it get injured? It can be due to some trauma directly to your knee simply. So you are going to see swelling, painful knee, and what's the problem? Person cannot extend his knee against gravity. That is your standing position, right? So patellar fracture, quadricep tendon tear, and injury to the patellar tendon. It indicates loss of knee extension. Okay, so um, for example, if you have damage to the patellar bone, the patellar tendon, so you cannot extend your knee, right? Because it helps in extension of your knee, like moving your knee like that. Okay, so injury to the patellar tendon. How to diagnose? Just have an X-ray for that. Okay. So now let's discuss shoulder and elbow. Okay, let me tell you some high yield points related to shoulder and elbow. So you know that your shoulder is basically made up of, you have a ball and socket joint. Okay, like it can freely move here and there, and it's basically stabilized by a group of muscles that are basically known as your, yes,
Rotator cuff,
okay, rotator cuff muscles. Can you just tell me the names of rotator cuff muscles?
supraspinatus,
Okay, there is
infraspinatus.
a mnemonic that is known as SITS, right? So,
Yes.
supraspinatus, infraspinatus, and
Teres
Rest
minor,
teres minor and
subscapularis.
subscapular.
subscapularis. Okay. So, what's basically the function of these rotator cuff muscles? For example, if a person is abducting, that is movement of his arm away from his body. So these muscles are going to stabilize this joint, right? It's going to put the humerus into this glenoid cavity, right? So if you have any rupture or if you have any damage to the tendons of these muscles, so it would be very hard to keep the humerus in its fixed position. That is the glenoid fossa, right? So the high yield thing which high yield point which you guys must remember is the common muscle which is going to be injured. That is your supraspinatus, right? In
Yes.
the rotator
Yes.
cuff. Okay,
Yeah.
why is there supras? Okay, what's basically the function of supraspinatus? For example, if this is your okay
Abduction.
scapula, right? You have a spinous process present on the scapula, right? Yes,
Mm.
abduction. So you have a muscle upon that spinous uh, process, which is basically known as your supraspinatus, as the name indicate, above your spinous process, and below this you have a muscle that is known as infraspinatus. So it's going to attach to your humerus like that, okay, and it's going to add onto the abduction, but from 0 to 15 degree only, all right? And
Mhm.
the from 15 to 100 degree your deltoid
Deltoid.
is going to do that function, right? So
Mhm.
if you have any injury to your, okay, why the supraspinatus muscle is prone to injury? Because it can impinge between, okay, this is the acromion process, right? So it runs like that. So, for
Mhm.
example, if I am just abducting my uh, arm, so it can become impinged between this, the head of your humerus and this acromion process, right? The tendon can become impinged. So that's
Mhm.
why it's prone to have rupture there simply. So you also have a U1 MCQs related to it. They'll be asking you that in the rotator cuff muscles, which muscle is prone to injury simply. That is your supraspinatus muscle. And what's the main goal of supraspinatus muscle? In order to initiate, right? From 0 to 15 min, I'm initiating the abduction, right?
Mhm.
Okay. So you have three bones in your shoulder. That is your okay. You have glenohumeral joint. This is your glenoid fossa, and this is your humerus bone, right? You have clavicle as well. The clavicle, your scapula, and your humerus. So they collectively form your shoulder. Let's discuss some shoulder movements. You guys know what's the flexion, moving your arm here. This is your extension. This is your abduction and adding adduction like that, and lateral rotation and medial rotation, right? Okay, rotator cuff muscles. You have four muscles surrounding the joint via conjoint tendon. Okay, you have supra. Okay, the mnemonic for this is sits, right? Supraspinatus, infraspinatus, subscapularis, and teres minor, right? So it draws humerus head into glenoid during abduction, as already discussed. During abduction, it's going to hold the bone, the humerus into the glenoid fossa. Okay, it can be okay, tendonitis, for example, inflammation of your tendon. It can cause this rotator cuff muscles to get weakened, or so as a result of that, you will be seeing pain whenever you are abducting, because the main goal of these muscles is abduction, right, or abduction. So you have your supraspinatus muscle here. You guys can see it is inserted on the head of your humerus, right? And it would initiate the abduction from 0 to 15 degree, right? Then your deltoid is going to perform the abduction above 15 degree to 100, right? Okay, it's basically innervated by suprascapular nerve. Okay, suprascapular nerve. The infraspinatus is also supplied by the suprascapular nerve. The most common rotator cuff injury, okay, you are going to see injury to the supraspinatus. We already discussed why, because due to impingement between the acromion process and head of your humerus. Okay, and this kind of injury you are going to see in swimmers. Why? Because they used to use their hand, and they, like, due to overuse or due to overuse abduction, you can, there is more likely for the supraspinatus to become impinged between this acromion and humerus, so it can be damaged simply, or throwers. Okay, so this is your supraspinatus muscle here. It can become impinged. Okay, how to check whether you have injury to your supraspinatus? That you have two tests for that. That is known as empty can test and full can test. What does we do in empty can test? Just stretch your arm, 90-degree abducted, then at 30-degree in front, just move your thumb down or move your thumb up. Thumb down mean you're emptying the can. Thumb up mean you have full can, right? And for example, if someone is applying pressure at that position and you have pain, so it would indicate toward, yes, injury to your supraspinatus muscle, right? So, arm stretch out 90 degree. This is a person. Arm stretch out 90 degree. Then in front 30 degree. Then thumb towards the ground, right? As you are emptying the cane, or thumb towards the sky simply, or you have full cane. And if someone is applying force to that to arm in this position, so it would indicate injury to your supraspinatus muscle. Okay. Then you have your infraspinatus muscle that is present. Okay, you have that is present below the spine here, right? Okay, what's the main goal of infraspinatus muscle? Muscle that is external rotation and abduction of shoulder. Here you guys can see. For example, if I am pulling on this muscle, so what happens? You're going to see an external rotation like that, right? External rotation or abduction, right? And this kind of injury to the infraspinatus is basically seen in throwers, that is overhead throwers like that. For example, if he's throwing the ball, that is overhead thrower, right? Or pitchers. So it's very difficult to assess the injury to your infraspinatus. Like you do not have the test like empty can or full can test. Okay, so it's very like you do not have an isolated test in order to see the injury of infraspinatus. Okay. Then you have your teres minor, right? Teres minor again is going to help externally rotate your arm, right? And it's going to help air ducting your arm. That is adding your arm inside, right? And it's basically supplied by axillary nerve. Okay, let me just discuss one of your U-World MCQs. For example, if someone have injury to his humerus, right, and it moves forward from your glenoid cavity or glenoid fossa. So which nerve are you going to see damage? Which you are going to see damage of which nerve?
Axillary?
Axillary.
Yes, axillary nerve. Perfect. Right. So, and you are going to see another sign as well, that is flattened deltoid. Deltoid will become flattened, right?
Yeah.
Okay. Then you have your subscapularis muscle that is present inside the scapula like that, right? Subscapularis. And it would help internally rotate your shoulder or arm. Okay, and it's basically innervated by the upper and lower subscapular nerve. Just don't remember these nerves name that are on high yield. You must know only the function which these muscles are doing. Okay, brachial plexus. Here you guys can see we'll be discussing brachial plexus tomorrow, but here you can see it. This is your suprascapular nerve, which are going to supply your supraspinatus and infraspinatus, right? Then you have your axillary nerve, which was going to be damaged in the injury. For example, whenever your humerus move like in front, like you have forward movement of your humerus from the glenoid fossa, so you have pressure on the axillary nerve. Axillary nerve is going to be damaged. Okay, it arises from the posterior cord. Then you have upper and lower subscapular nerve, which are going to supply the subscapularis, as the name indicates. Okay, anyone who can just revise these rotator cuff muscles? Okay, from here, Osgood Sattler syndrome. Yes, Dr. Renu.
Yes, Dr. Amal.
Yes.
This Osgood-Schindler disease is seen in children, and
Okay.
what happens is like at the tibial tubercle, there is like pain and swelling because of the overuse.
Yes.
It is like usually like self-limiting, and that is the secondary ossification center of tibia.
Okay.
Mm.
Okay, can you just tell us about the rotator cuff muscles? What are the function of that? Which common muscle which is going to be injured? How to assess whether the injury of that and what's
Yeah.
the nervous supply?
So the rotator cuff muscles, we can remember it by the mnemonic sets. So it is like supraspinatus, infraspinatus, teres minor, and the subscapularis.
Yes.
And so the supraspinatus muscle is like it initiates the abduction from 0 to
Okay.
15 degrees.
Yes.
Yes, and for the assessment of it, we use the can test, the empty can test, and the full can test.
Yes.
And then the
Okay.
infraspinatus.
It's
Yes.
most commonly like injured muscle or the tendon is most commonly injured. Why?
Yes, because it is like above the spine of the scapula, and there is like the coracoid process of that. So, and it is
Acromion
like
process.
acromion process. Sorry,
Yes.
so I'm a little bit bad with this. So, so it is like very easily impinged. That is the that structure, the supraspinatus.
Okay.
Yeah, and okay. So it will
Yes.
occur most commonly in the swimmers and throwers.
Yes. Introverts, right? Then
Yes,
you have
yes.
your infraspinatus. Yes.
Infraspinatus, as the name suggests, it is like below the spine of the scapula, and the
Yes.
function is like it helps in external rotation and abduction. And it is seen in like people who are like pitchers, like because they have to throw overhead. So they're like overhead throwers.
Yes. So,
And it does not have any like specific test to assess.
uh, so
Then, mhm. Then we have the teres minor, and teres minor function is like external rotation and adduction, and it is
okay.
supplied by the axillary nerve. And in humeral fracture also, the axillary nerve is gone, and in that case, we will see a flat deltoid.
Yes.
Then last is the subscapularis. Subscapularis main function is the internal rotation.
Yes. Internal rotation.
Yeah, and it is like upper and lower subscapular nerves, the nerve
Okay.
supply.
Okay. Deltoid, as we have already discussed, it's going to contribute in abduction. That is for 15-degree onwards till 100-degree or 90-degree, right? And above the 90-degree, your trapezius and serratus anterior. This is your
Serratus
trapezius, your large muscle here. Is going to help abduct your arm further. Okay, shoulder dislocation, as already discussed. Anterior dislocation of your humeral head. Okay, how can it be damaged? For example, if I'm abducting, externally rotating, or extending, right? Like blocking a basketball shot, for example. So, or tackling while throwing a football. So, it can have damage to the axillary nerve, right? Why? Because axillary nerve basically wraps around the humeral head. Yeah? Okay, the humeral head, the neck. Okay, so you are going to see sensory loss of deltoid. Okay, and basically you are going to see weak abduction. Okay, guys, I think like it's very hard. Like I have just like in this lecture I'm just reading from slide, so I think I'm not enjoying it seriously, right? So tomorrow, let's continue our class tomorrow, and tomorrow I'll be doing in my way. Whether I'll be drawing the diagrams, I just prefer to read these slides because like it was very hard for me to like draw this structure. Either you could understand or not, but like I'm having issue just reading these slides. I am not enjoying simply. Okay, so tomorrow we are going to continue this lecture, and I'll be just taking class on my notes like that. Okay.
Yeah, that is much
Okay.
better.
Yes, like I'm not enjoying just reading these slides and all of those stuff. Okay, I also was making slide and I was in between, but the class came, so I'll complete that as well, and we'll do in our own way. I'm not just like enjoying this lecture. So, guys, okay,
Okay.
yes, I'll just share this slide. So, thank you. Tomorrow we are going to finish off the anatomy, but I'm just looking for some best slide resources. I didn't like this doing boards and beyond than just reading, right? So I'll prefer to do U world slides. So tomorrow we are going to discuss those. We have already discussed a lot of the high yield concepts, but just reading these slides, I think it isn't interesting. Just only read this one. Okay. So thank you guys. Have a nice day.
Dr. Ahmed,
Yes.
what will be the next system?
Okay, so tomorrow we'll have an extended session. We are going to complete the MSK, and right after MSK, we are going to do. Okay, right after MSK, we are going to do GI.
Say biochemistry.
Biochemistry. Biochemistry is a side. Okay, neurology. What do you guys think? What should we start?
I think either GI
You
or
can
neuro.
start neurology or GI or reproductive. Three
Okay.
main systems are left.
Okay, let's do neurology. Okay, and we'll be discussing
Yes.
neurology in detail. And for neurology, like these once MSK is done, we'll be discussing neurology. And as I have already told you, I'm going to take all of the classes of neurology, the neuroanatomy, and all of those things. So we are going to have an extended sessions. So yes, let's start neurology.
Okay.
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 Yes, we
Thank
are
you.
also going to start NBMs. Basically, I'm working on a lot of stuff. Like I was just uploading the Anki's flashcard as well, and I'm making a platform for NBMEs as well. So nowadays, sorry if I'm drained out here in class. Okay. So yes, we'll be starting doing NBMEs.
Doctor, when you will share with Anki?
Like it would take a day or two. Like currently I have just uploaded around about 1,000 of flashcards, and I'm remaining with the other thousands. So I have also contacted some. I have hired someone to help me upload these Ankis. So in 2 to 3 days we are going to see these Ankis being uploaded, right?
Doctor, how many systems are in Anki will be
Oh,
included?
all systems, all systems.
Oh, thank you.
Okay, thank you. Have a nice day, guys. Thank you.
Thank you,
Thank
Dr.
you.
Neil.
Thank you.